Hello everybody, welcome to the review of how we at Sequoia Hospital stop pressure injuries, we being nurses, aides, and physical therapists. Before we get into it, I want to congratulate everybody. Since we started paying attention and doing some really good work, all our pressure injuries started to go down. The red ones are reportables, and those are the ones that really get us into trouble, and those are way down. But the blue ones are the non-reportable hospital acquireds. They're going up probably because we're getting better at doing our skin checks and noticing when something's going on. 7 easy steps to preventing happies at Sequoia Hospital. First, bedside PIP risk assessment and skin check. Not everybody's a PIP patient, but everybody needs to be considered for it every day. Photograph any wounds that you see, suspected pressure wounds. Order a wound care clinician eval and treat for any wounds that you see. Tag and notify all PIP patients so that all staff know that they need to be handling this patient with extra care. Routine PIP interventions are started. Of course, we need to offload the pressure. We need to prevent moisture contact with the skin. We need to prevent friction and shear sliding and improve nutrition. The PIP and wound check. PIP patients need their skin and wound checked more often, actually at every opportunity. The sooner we see a problem, the sooner we can do something about it. Chart your interventions and in a defensive and reality way, talking about all the complications. The most important risk factor is what does the patient's skin look like, especially over bony prominences or areas that are under moisture, pressure, or friction and shear. What is the skin trying to tell us? That's why we say you got to check the skin as often as possible. You should do your Braden risk assessment pretty much anytime you walk into the room because it's quick, easy, accurate, and it gives you time to plan the care. All you have to do is ask yourself, is the patient protecting themselves from pressure, moisture, friction and shear, and do they need better nutrition and hydration? Specifically, what are we looking for at the bedside? Well, immobility is the most obvious. Healthy people adjust and naturally move themselves off pressure points about every 15 minutes. So if your patient is unable to or does not move, they're at risk. Moisture. There's a lot of incontinence around here, but most people don't allow their skin to remain soaked in urine and stool, and they don't allow it to collect under medical devices. So if your patient is allowing this, they are at risk. Friction and shear. Most people that can correct when they slide themselves down, they don't slump, and they're not so restless that they're damaging their skin, and they can boost themselves. So if they're too heavy to lift during boost, they are at risk. Cannot feel. If they can't feel excessive pressure or whatever because they're over-medicated or maybe they have a neurological disorder, they're not going to be able to protect themselves, so they are at risk. Skin. If the skin is fragile and we're interested in the skin over or under medical devices or pressure points or moisture, then they are at higher risk. And of course, signs of skin damage, or if a patient already has a pressure injury, that means they're at risk. It's fair to say that if a person doesn't easily and spontaneously offload their pressure points, protect themselves from friction and shear, and keep their skin clean and dry of moisture, then they could be at risk for bed sores. But how do you know? Fortunately, you can assess this easily and quickly at the bedside, assess all the Braden factors at the bedside, the most important being mobility and activity, which we go over here. I forgot to mention in this video also that you should also see if the patient's able to lift their heels off the bed and move their feet around. And of course, if the person's contracted or tends to sleep in a fetal position and only on their side, then of course they need to be turned to the other side and turned also. So here we go. To test a person's mobility at the bedside, lower the head to bed to flat and ask them to turn. Don't help them or push or anything. If they lift their shoulder, obviously they're not offloading their sacrum buttocks area, and obviously they're not mobile enough to offload their pressure points. Sometimes they'll actually be able to turn just a little bit, lift their hips up off the bed, but when they let go, they flop back down and right on their back again. Obviously, if they can't turn and rest on their side, they should be put on PIP protocol. Sometimes a person can turn and lay on their side upon command, but when they're not asked to do so, they stay in one position. This is why you should consider the patient's activity as well. When people are healthy, they lift, shift, turn almost constantly while they're laying in bed because our sensation, reflexes, and mobility is enough to know when it's time to offload pressure. But when a person doesn't move for the duration of while they're lying in bed, their activity is low and their pressure points are not being offloaded. Sometimes the activity level is a clinical judgment call because it's hard to know what they're doing when you're not in the room. But if they're in the same position they were in last time you were in the room, that's a hint. When in doubt, you'll have to watch the skin closely over bony prominences to make sure there's no signs of irritation or wounding at every turn and every pericare. If you see signs, you're going to have to do the turning and repositioning more often. You can also easily check if the patient's at risk for pressure injuries at the bedside in a few minutes by looking for these 4 things. Obviously, sometimes you can't correct these risk factors, but at least you notice them and you can start making a plan to correct them as soon as you can. First of all, is the patient out of position? Did they scooch off the wedge or did it slide out of place? Is the pillows bottomed out and they're back on their wound? Or is the patient in a slump position? Slump position is the worst position you could leave a patient in for so many reasons, and if a person can't correct their own slumping, they need your help. Are the heels digging into the bed? This also only takes a few minutes, most of the time just a few seconds to correct, lift their heels up and correct the support so that their heels are floating. Of course, are they moist again? Are they soiled with urine and stool, or are the linens wet from sweat or drainage or weeping? These can usually be corrected quickly, but if you have to do a full pericare, you can start planning to get a second person in there to do it with you. Repeated sliding, friction and shear. Do you have a slider in there that's just making the person slump again, and now everybody's running around doing friction and shear boosting over and over again? Meaningful use of the sliders is really important. We'll go over that separately at the bedside. Of course, is the skin damaged? Do you see damage when you're doing the pericare, when you're toileting the patient, or when the patient's moving or with physical therapy? Always peek at the skin. Is their skin irritated? Most irritation over bony prominences is a precursor to bed sores. So check the skin, check the skin, check the skin. The red photo phone can be found at the docking station on your floor. You should take a photograph of all pressure injuries upon discovery, even if you discover it 4 or 5 days into the admission. If it's ordered, no, we're not asking you to take daily photos to punish everybody. We need daily photos sometimes because we need to closely monitor the progress of the wound. If the wound is getting worse, you take a photo of it anytime you want to. Okay, here's the easiest thing to do and the hardest to remember. Tag the patient. Put up the PIP sign on the front of the room. Apply the PIP wristband. Tell the aides so that everybody knows this patient needs to be turned and repositioned. Tell the charge nurse so we can have record of it for the next shift. Order a skin care order consult and initiate the skin care plan. Okay, you're ready to initiate PIP bundle interventions, and the first question that always comes up is how often should we turn and reposition? The answer is as often as the patient needs it. Listen, nursing care, as we all know, is not the kind of thing that you can just drop what you're doing every 2 hours and go running into a patient's room and turn and reposition them. That's not the way we can operate. We need to know that PIP care is not a separate obligation dictated by how much time has passed. It is a core nursing function that must be incorporated into your routine. What does routine PIP care look like? Well, patients who can't and don't independently mobilize and clean themselves should get help doing that at least every 4 hours. Turning and repositioning certainly is also mobilization. So that would be after meal times, at bedtime around 10 o'clock at night, around 2 a.m. and around 6 a.m. How do we know when a patient needs to be turned more often? Well, again, look at the circumstances. PRN means you need to do it again because you need to restore the pressure relief. They need to be clean and dry. They need the friction and shear reduced, and of course, if their nutrition is poor. The other thing is skin check, skin check. This is why the skin check is key. Our job is actually to heal pressure wounds, heal incontinence dermatitis, and heal moisture-associated dermatitis. So if it's not working, then we need to do something differently, especially if the patient has a really bad pressure injury. They need care more often. Friction and shear injuries, that is, sliding and sticking injuries, is the second most common reason people get bed sores, and I find that most caregivers don't know the secrets to preventing friction and shear injuries. So here we go. First of all, manage incontinence well. Normal skin, healthy skin can usually handle the sliding around in the bed, but when they're soaked in urine and stool, they become much more fragile. So don't allow the skin to soak in urine and stool, and use moisture barrier cream. Use moisture barrier cream. It helps with friction and shear, and it protects the skin. Minimize boosting. A lot of caregivers just keep reboosting and reboosting, so the tricks to minimize boosting is keep the head of the bed as low as possible. Yes, some people can't have it low because they need to breathe or eat, but get out of the habit of just automatically raising the head of the bed because you're in the habit of doing it. Also, meaningful use of sliders. Sliders actually cause sliding and slipping, so sometimes we have to use sliders because the patient's too heavy to boost independently or move independently, but you have to be careful. Don't use them on somebody that doesn't need it because they actually cause friction and shear injuries after a while. Meaningful use of the Optifoam, otherwise known as Mepilex. These are the heart-shaped round pads. They're very helpful to prevent friction and shear, but they tend to absorb urine and stool, and they tend to fall off and roll up and cause more problems than they solve. So use them meaningfully and make sure that they're intact and clean and dry. We want to go over the fundamentals of turning and supporting the pressure relief position because it's key to preventing pressure injuries over the tailbone sacrum area where they are the most common. I know some people are harder to achieve sustained pressure relief than others, but remember that the wedge is going to be more effective. Pillows absolutely do not work unless the patient weighs less than 100 pounds. So even though the patient prefers pillows, they probably prefer them because they don't support a turn position. So hang in there, watch the fundamentals, and adjust and accommodate your positioning to suit the patient's needs. Okay, now you're ready to turn and set the wedge. You're always going to get a much better set when the patient is fully straight and parallel to the bed and closer to one side. Bend the knee and turn them over. Now the wedge can be set under the underpad, but for demonstrative purposes, we're going to set the wedge over the pad. Because when you do that, it's a lot easier to see where you're setting the wedge and where it's going to lift from the body, and it's a lot easier to get it under her. Notice how Lisa tucks it under. That makes it a lot more stable. And when she rolls back, the wedge is all the way underneath her and she's resting on top of it. It doesn't work to try to punch the wedge closer once the patient's laying on top of it. So if you want the wedge closer, you'll have to reset it. Setting the wedge to lift from the buttocks and scapula is best when the patient can rest supine, and it mostly circumvents the spine and the coccyx. Here is a standing view of how to set the supine resting wedge. If the patient must rest in the head of the bed greater than 30 degrees, then it's better to set the wedge a little bit lower so it's lifting under the sit bones and the back, just about like this. Or if you're trying to avoid a large wound, you have a heavier patient, or they won't let you turn their back, you can set it very low so that it's lifting only the hips. When side turning is not possible for whatever reason, you can put a wedge on both sides, although this is more difficult and it doesn't achieve complete pressure relief. Okay, so now that you've set the wedge where you want it, roll the patient back so that she's resting on top of it, and you can stand at the edge of the bed to make sure you've got the 30-degree angle that you're looking for. What's next, Kristen?
And you can see there's a lot of weight still on here, so we're truly not offloaded. So what we're asking you guys is to make sure is to, as soon as we bend that leg, you've offloaded the weight. So you can either bend the leg and they can keep it that way, you can use it, or you can use a pillow to support. Like that, and you can, even if you have the leg fairly straight like this, you've still got more offloading than if it was on the ground or on the bed. Ideally, you have it pushed a little bit forward so that you're in a good alignment. All right, so we also want to make sure we place the heel bed, so we'll go ahead and raise up the legs, slide it under. Ideally getting the ankle area heel into the groove of the heel bed.
Okay. So fortunately, it's easy to reset the heel so that there's pressure relief there. The hardest part about it is remembering to look and do it. So instead of using simple pillows or foam boots, use the heel floater. It has grooves here where you can float the heels or ankles, and you can rotate it as the patient moves, and you can bolster the side rails to help prevent against foot drop. Also, you can use the pads to pad the feet so that they're not pressing against the rail. There is a tendency to assume that once you get the patient in the chair, you're off the hook for pressure injury prevention, but it's not true. You have to pad the chair. A simple pillow will work for a lot of people, but if they have really super fragile skin, please use a cushion or the cushion with a pillow. Or you can use the chair waffle here, but please definitely cover it with a sheet at least, or a sheet and a pillow. There is a lot of stigma around pressure injuries, and it's usually because eventually we play the blame game when someone gets one. But the truth is, there is very many complications that can happen when we're trying to accomplish turning and repositioning. First of all, we're unable to do it right. For whatever reason, we can't keep the pressure off, we have trouble preventing the friction and shear, or we have trouble managing the moisture. 2, the patient objects. Yes, sometimes the patients automatically object. They don't like to turn, or they think the pillows are actually a turn, even though the pillows don't turn them. This is not to be confused with an oriented refusal. Yes, some people definitely flatly refuse to turn, even when they have a bed sore. So here's a few suggestions that I want to have in the forefront of your mind to think about. First of all, please identify the issues and discuss and explain to them why don't they want to turn, or what's going on, why are we having trouble keeping the pressure off. Look at these issues and try to manage them and discuss them with the patient. 2, the skin check. Maybe we can let go of the turning if they can't do it or they won't do it and we can't do it. The skin check is really important. Please do a meaningful skin check, because if maybe we don't have to put anybody through this if their skin is tolerating it anyway, but if it's not, then we have to really get on the ticket with it. Defensive charting. Do chart your discussions with the patient. Do chart what you've tried to do, and do chart when you have complications that have nothing to do with what the patient is doing. But you're just having trouble keeping them on their side for whatever reason. These are key to keeping pressure injuries at bay. There is a direct correlation between the complications with turning and repositioning and the incidence of pressure injuries. So you want to chart as though you're trying to explain yourself to an attorney. The best way to do that is to chart everything that you've actually done here in the pick list boxes, but also free text down here. You can do it in event notes, or you can do it in the position other, where, for example, you would say 2 caregiver assists a 30-degree lateral turn supported with a wedge, or, for example, refuses turn due to back pain, will try again later. Again, when you're having trouble, you don't want to just throw up your hands and tell every other shift next time, don't even bother, the guy will say no every time. No, we still have to be concerned about our preventative measures, because we're still on the hook. It is our responsibility to make sure we do everything we can to prevent a skin injury. That concludes our overall review of pressure injury prevention. Thank you guys. We're doing a great job. Keep up the good work.